Good afternoon, everyone. Welcome to today's panel discussion on overcoming PCOS during IVF. Way Forward, hosted by ETHealthWorld in association with Bharat Serums Limited. Polycystic ovary syndrome is considered to be a multifaceted disease with a spectrum of manifestations affecting not only women of childbearing age, but also adolescents and postmenopausal women. PCOS is the leading cause of anovulatory infertility in women. Today, along with the elite panel consisting of Dr. Suparna Banerjee, gynecologist and infertility specialist, Ankur Fertility. Then we have Dr. Dipesh Sorathiya, infertility specialist, Khushi IVF. And then we have Dr. Madhupriya, who's a fertility specialist with Noah IVF, are going to discuss what are the causes of PCOS, its impact on pregnancy, and how it can be overcome. So without further ado, let's go ahead with this panel discussion. So my first question is directed to Dr. Banerjee. What are the most common causes of PCOS? What is the impact on pregnancy and IVF treatment?
Okay, PCOS has got a kind of ethnic relation and genetic relation and some lifestyle issue. So the causes of PCOS, you can say we Asian are very prone to develop polycystic ovary due to our ethnic reason. And then the lifestyle, I will come to genetic issue last. Because it is a multi-genetic factor. So lifestyle issue is a big factor. And in the world, female obesity, in respect to female obesity, India is on kind of second or third in the world. So obesity is rising from child to adult, everybody. So that's why the polycystic ovary incidence is also rising, because it is basically a problem of your hormonal imbalance. That is, key factor is insulin resistance, and insulin is the key hormone for carbohydrate metabolism. So carbohydrate metabolism is the main problem, and as a result, hyperandrogenism, that is the androgenic hormone, becomes excessively overactive. So that's why the all spectrum of disease is just rounding on the basis of these two factors. Now coming to the genetics, we see some of the PCO cases. It is kind of in generations, or in two sisters, they both have polycystic ovary, and it's probably mother. So it is a kind of a genetic relation is there, but not a particular gene is related to it. As you see, it is a metabolic problem. So when there is problem in the insulin resistance, means insulin receptor problem. So there is problem in the receptor, post-receptor level. So it is very complicated. So to make it more simple, the main cause is problem with the insulin hormone is there, but it is not working properly because the problem in the receptor. Now, how we can improve the pregnancy or IVF success, whatever you say, main problem is anovulation, because of this insulin is not working. That's why adipose tissue is excess, and as a result, high androgenic hormones are taking upper hand. So the ovulation is arrested. So our treatment motto always is first the lifestyle management, and how the medication we use here just to lower or decrease their insulin resistance, so that the hormonal milieu is turned towards normal and androgen will be lower. And though no anti-androgen directly we use, but androgenic milieu will be lower, and then the ovary can be easily stimulated. So the outcome of this pregnancy related outcome, will say sometimes it is good, sometimes bad. If they are not well controlled polycystic ovary, there are multiple complications in pregnancy, from falling pregnant, it is difficult, then early pregnancy, miscarriage risk is there, then gestational diabetes, hypertension, all risks are very high if they are not well controlled polycystic ovary or obese PCO. In those cases, risk is high, early preterm labor chance is high, poor prognosis. But when it is a very good control of polycystic ovary, so their hormonal milieu is towards normal, and then the outcome is good.
Thank you, Dr. Banerjee, for your inputs. What would Dr. Sorathia would like? Would you like to add something to this?
Whatever the causes, Madam has explained very well. Just wanted the impact on the pregnancy and IVF treatment. The impact, usually 20-30% of the PCOS patients, they conceive naturally. Most of that, with especially the obese and thin lean PCO that we told in our language, that require the medical management Out of that, especially obese, they require the multiple, mostly IVF cycles due to anovulatory problem. They are not responded very well. And still, the main thing that is lifestyle changes in form of the weight reduction for the especially the obese PCOS. There is no proper lifestyle modification that can be implemented in the most of the cases. So most of the PCOS patient, 70% of the that require the fertility treatment, and most of around out of that 30-40% will land for the IVF treatment.
So Dr. Sorathiya is saying, like, out of all the patients suffering with PCOS, 30-40 of them would require IVF treatment.
Yes.
Thank
So
you so
there
much
are there are also regional differences. North, south, and west. There are the incidence of the PCOS are the different. You can say South India, where I have the few initial years. There are a lot of PCOS patients I see in the south. Regarding the north, there are a lot of especially in the Punjab with Punjab and high BMI patient. They have a lot of PCOS patient. In the western that we reside in Gujarat, now obesity is on the rising due to the lifestyle. We see the many PCO cases. Initially, we used to get the less number of PCO cases.
Dr. Madhupriya, what would you like to say on this?
Hi. First of all, thank you so much for inviting me to this webinar. And now, as far as the causes are concerned, as they rightly have told, there are two reasons. One is genetic, the second is environmental. And genetic is something where they are scientifically searching for what the gene that would be responsible for the obesity, leading to insulin resistance and leading to polycystic ovaries and increasing severity of the condition. And there is a gene called OB gene, which is responsible for obesity in adults and in adolescents, which can also be sometimes related to the insulin resistance in PCOS women and people with obesity in men. Now, coming to PCOS, there are also environmental factors which forms a major role, mainly because even a lack of appropriate food intake, not a very balanced diet, increasing weight gain, all these have found to have an inappropriate circadian rhythm, like even a loss of sleep probably, can actually post a rhythm to this polycystic ovary and lead to abnormalities like increase in weight gain, leading to abnormality in PCOS, which in turn increases the weight gain, which in turn increases the polycystic ovary severity. So a multi-prong, or because this is a multifaceted problem, it's important to have a multi-prong attack towards the causes. So dealing them both as a family. For example, if a family is of Asian ethnicity and they're of a Hispanic origin, and people have diabetes running in the family, then they are at high risk of going ahead with a polycystic ovary, plus metabolic problems later in their life in the form of diabetes, hypertension, and even a cardiovascular disease. So the causes from the root we need to identify. And as far as the environmental reasons are concerned, obviously having a very good lifestyle, like with a balanced diet, good hydration, appropriate sport activities, appropriate exercises, and diet habits tailored to the particular person will help treating the PCOS lifestyle changes in a long way.
Thank you so much for your deep insights into this, Dr. Madhupriya. So moving ahead, the next question that I have is Dr. Banerjee. What are the challenges in treating a patient suffering from PCOS, and what are the success rates?
So first challenge is to make them understand about the process, because when they are coming to us as a infertility patient, they just want their somehow make me pregnant, doctor. But that is not the issue. I always tell them, if you do not have a good healthy body, maintaining your BMI, good healthy diet, exercise, it's not that I can make you. They think IVF is the last solution and we will make the baby, and they think, okay, then that's fine. But the problem is pregnancy is a 9-month journey. So many things can happen. So if they are not fit in the first place, then they are going to miscarry. Or preterm labor is very common, because if they develop gestational diabetes, the chance of infection from the vaginal route or urine infection, these are very common. So these all are threats to her pregnancy. So the thing is, low carbohydrate diet is the key. So they can have some protein diet and fruits and fibers, but low carbohydrate diet, and throughout the pregnancy also they need to maintain that, so that their chance of gestational diabetes will be low and they can maintain the pregnancy. And ultimate goal is a healthy full-term delivery. That always need to be counseled to the patient beforehand. So pregnancy, only making the pregnancy is not the solution for the problem.
So I'll repeat the question for you. What are the challenges in treating a patient suffering from PCOS, and what are the success rates?
So as discussed, the PCOS is a lifestyle disorder, particularly nowadays. So the most important part, when the couple land to the basic gynecologist or when they come to the fertility clinics with the fertility consultant, when the best thing is to understand what is the root cause problem, that is the lifestyle disorder. So we have so many patients that come from the routine gynecologist after failed multiple cycles or that thing. We run the PCOS clinic in our hospital. So that had a multi-disciplinary approach, like it involves the fertility consultant, involves our bariatric team that have the very good dietitians and the counselor and the endocrinologist. So all this help to change their lifestyle. You can't just say you have the 65 kg weight and come after the 60 after 3 months you come with the 60 kg of weight. That is never possible in their lifestyle, because some are IT people, some are job working, they have the night duties. So you have to understand their lifestyle, and then you have to suggest how you can make your life healthy. You just can't tell them you stop doing this one and this one. So it is a multiple disciplinary approach that helps the female plus their family to get on the healthy lifestyle. After that, even that require they should go for the pregnancy journey, because if they are on the weight is control, BMI is control, other medical disorder like thyroid, diabetes, everything is as that control, then treating the PCOS patient would be very easy. And regarding the success rate, most of the PCOS patients conceive at the end of the whatever the fertility treatment. Very few, very uncontrolled PCOS patient with very high that have certain times have the very poor quality of eggs, and they have and 3 times they have a lot of abortion chances. They are difficult to conceive, but at the end, everybody has a happy end.
Okay, so Dr. Sorathiya is saying that the success rates are pretty good until unless there are other medical complications attached with it.
Yes. Yes.
Dr. Madhupriya?
Yeah, I just would like to add that a wholesome approach to the patient is very important as far as this lifestyle disorder is concerned. So one, apart from changing the lifestyle, which will involve a tailor-made physiotherapy, tailor-made diet plan that suits the particular patient. And going ahead with the lifestyle changes, which they could bring in, even losing about 5 to 10% of the body weight, not that they have to go back to their ideal weight or ideal BMI. Even a minimum, whichever they can try with a tailor-made diet and physiotherapy, it has to be more of a supervised treatment, tailor-made to that particular person. And if a 5 to 10% loss of weight happens, then they are going to have a real increase in the success rate by about 10%. So apart from the lifestyle changes, which is definitely going to help them, there are various types of treatments, which involves just treating them with minimal tablets, which will help the egg production to happen. Basically, what happens in polycystic ovaries is there is no egg production happening. To say in common terms, if this is the amount of hormone that is needed to produce egg, the lady has a very high level of hormones. So to bring them back to the normal level of hormone, it's important that they have some tablets For some people, they just respond to tablets. Some of them don't respond to tablets. They respond to tablets and injections, but they could conceive naturally. But some of them will need laparoscopic procedures or some even an IVF to control the hormone balance or the insulin resistance to allow the follicle to grow. So basically, the anovulatory cycles or the cycles where they do not produce any egg needs to be converted to ovulatory cycles, which means they are producing eggs now. We are combating or we are overcoming the challenges which is forced onto us by the hormone imbalance or the insulin resistance, basically, in polycystic ovarian women. So all these are the armamentarium that we have, either giving tablets or only tablets and injections with natural cycle, provided the male factor is fine, the tubes are okay, the uterus is good to go ahead with implantation, then their sexual life is normal. In that case, yes, even a natural cycle could help them with some tablets and injections. For some people who do not, have ovulation even with these medications, then we need to take higher steps like IUIs or IVF to make them pregnant. So it is tailor-made. Each treatment to a PCOS is unique and it is tailor-made to that particular person. Believe me that out of 100 PCOS women, nearly 70% become pregnant even without knowing that they have polycystic ovaries. Only 30% of women in the society have either irregular cycle or weight changes or fertility issues that they have to come up to the gynecologist or the fertility specialist for help. And yes, we do have many different armamentariums to help them specifically.
Coming back to Dr. Banerjee, since there was some technical glitch, Dr. Banerjee, if you could just sum this up quickly.
Yes, already I think that most of the discussion is done. So definitely first lifestyle changes. If they are back to their normal ovulation, then chance of conceiving normally, as my previous speaker already mentioned, is very good. And if it is still not happening or other issues like husband count is not very good or tubes are not patent, in that cases, depending on the situation, we can offer them IUI or IVF. Because we are getting a good number of eggs from these patients, so chance of conception is not an issue. Most of the time, they conceive easily, but sometimes some difficult cases are there where we see either their endometrium is not good. I have experience with this polycystic ovary, one group of polycystic ovary. Even then, during the stimulation, we find that endometrium is not growing somehow, and sometimes in excessive growth. So quickly some endometrium is going, they're getting multiple times polyps. So there are extremes of patients, and some polycystic ovary, they behave so normally. When they maintain their weight and diet, their ovary morphology just look like a normal morphology, but we know, we have seen this patient with polycystic ovary. So it is the spectrum of disorder, I will say, and depending on where you are in the spectrum, your prognosis will be like that.
Thank you so much, Dr. Banerjee. Dr. Banerjee, coming back to you. Question is, what are the chances of pregnancy complications with PCOS and how can they be managed and averted if that is the case?
Yeah, again, the complications in the early pregnancy, there is chance of miscarriage is very high. Number one is either this is the hormonal milieu. When the hormonal milieu is altered, there sometimes, suppose when it is a natural conception, so sometimes progesterone hormone, which is secreted from corpus luteum, is not good enough for those patients to holding the pregnancy, so chance of miscarriage is very high. So most of the gynecologists give progesterone supplementation because we know the hormonal milieu is not that good. Or otherwise, even in IVF pregnancy, where we give loads of hormones, sometimes still the quality of the embryo is not that good. Then also they miscarry. So it's basically the first trimester miscarriage risk is very high for them. When they come to second trimester, the chance of developing gestational diabetes is very high, and as a result, chance of urinary infection, chance of vaginal thrush, this also increases, and that might lead to there are the preterm or PPROM, we say preterm premature rupture membrane, and going into miscarriage, second trimester miscarriage, or very early labor, like 26 weeks, 27 weeks, 28 weeks. These are very difficult times for the baby to survive outside. in the world, but sometimes this can happen to them. And this chance of hypertension, that is the preeclampsia risk, is also very high. So basically, when they, the lifestyle management is good, we can catch them early with their, if there is any gestational diabetes developing, we catch them early, treat them, or we can avert the gestational diabetes at all, because she's making, she's taking good low carbohydrate diet and doing all the right thing. Then usually the prognosis will be good, but always we need to monitor them very carefully and very closely.
Thank you so much, Dr. Banerjee. Dr. Sorathiya, what would you like to say on this?
Madam has explained very well the complication that happen with the PCOS when they are the pregnant. The only thing that can be managed, it's most of the complication can be managed. How to avoid that is it's the important thing. Is the prevention is better than the complication. So the important aspect for all PCOS patients, again and again, everybody is discussing that the lifestyle modification. So better the initial start the things that help to avoid the all type of complications, especially the PCOS, as Lee said, they have the 3 to 4 times higher abortions rate. They have the higher chances of gestational diabetes that lead to the certain postpartum and intrapartum complications like high baby weight that lead to the operative deliveries and the surgical complication that happen with the PCOS patient. That can be avoided with the earlier good lifestyle.
Thank you, Dr. Sorathiya. Dr. Madhurya?
Yeah, basically, polycystic ovary patients, whoever conceives or who is in the process of conception, needs to be monitored right from the preconceptional period. The periconceptional period on the whole is very important, not so much so, even following up these patients in the interconceptional period before the second delivery that she tries for is also very important. The lifestyle management not only restricts itself into the pregnancy period or the preconceptional period, but also extends after her delivery, because nearly 50% of women who have this polycystic ovary and who develop gestational diabetes during their pregnancy can become diabetic over 40 years of age. So it's a very important metabolic disorder which can lead to anticipatory phenomenon. That is, if the previous generation has had diabetes at about 60 years of age, these people with polycystic ovaries can have their diabetes starting at a very early age, like 40s. Even now, even in our generation, we see many people having diabetes right in the younger age group. So this is something which we have to look into. And yes, lifestyle modification is very, very important. And that's why it's been repeatedly told in this webinar many a times, because an appropriate balanced diet and an exercise which is, tailored to them are very important right from the preconceptional period. And yes, it is important to prevent miscarriages in the early trimester, important to make sure that their sugar levels are maintained right before pregnancy, during the pregnancy, throughout with medications. And there are safer medications available, so people don't have to worry that they are taking medications and whether that would harm the baby. No, it doesn't. And it is very important to take those medications to keep the maternal and the fetus glucose levels under control so that there happens no complications later. Why are we worried about the complications in the baby is because, as beautifully told, around the time of delivery, the baby, which is going to be on the higher side of the weight, or the baby, which is going to be very small, will have their own complications during birth. They may have suffocation to breathe. The bigger babies may have difficulty to get delivered, so necessitating a high risk of cesarean. There is high chance of going ahead with instrumental delivery, which may all pose a little more risk to the mother. And the baby by itself can go in for a low sugar levels after delivery. And there could be electrolyte imbalances in the baby as well. And the baby can carry the metabolic syndrome right through their genes until about 30-40 years of age, that they develop diabetes, hypertension, and cardiac problems. That's the heart-related issues earlier in life, like 30-40 years of age. So to avoid all these, it's important to start planning right in the preconceptional period, especially for a woman with polycystic ovarian syndrome, whom we know is already at risk compared to the other women, other normal women.
Thank you, Dr. Madhupriya. Moving ahead, my next question would be, what are the weight biases associated with PCOS and how can one manage it before pregnancy, during pregnancy, and postpartum? Dr. Banerjee, what would you like to say on this?
Yes, I think we have already discussed regarding biases. So before pregnancy, as Dr. Madhupriya rightly just now mentioned, that many of the adulthood disease, their seed starts from in mother's womb. So if we have to make a healthy progeny, healthy generation, so before pregnancy, if the mother, that is the preconceptional period, if the mother is healthy, then she can make a good progeny. So we need to make them understand that. So if the pre-pregnancy BMI is normal, especially they are, because it is a metabolic problem and metabolic problem of insulin hormone. So low carbohydrate diet and regular exercise to keep them fit and healthy, so that their ovary is functioning normally. Then they can avert so many risk factors which is going to develop otherwise, obviously during the pregnancy. So, and then they keep them, the maintaining, because we know there will be some weight gain in pregnancy, but a healthy weight gain, we need to know what is healthy weight gain, what is unhealthy weight gain. So I always stresses to my patient that healthy weight gain is throughout the pregnancy, they usually gain 10, 12, 14 maximum kilo weight from the preconception until full term. So if some of the patient is gaining weight very quickly in between two visits, if there is after 5 months, usually weight gain starts properly. So if somebody is gaining weight within 5 months, that is also a risk factor, because she is taking too much of carbohydrate and because she could not do a strenuous exercise at this point. So, and if it is in between two visits, if per month she is gaining more than 2-3 kilo, then that is also abnormal in second and third trimester. So we need to keep an eye on what they're eating. Again, here dietitian could play a big role, so that they could have a proper nutrition, because they are pregnant, their need is much more. So protein, calcium, all the nutrients should be there, but at the same time, carbohydrate should be low, so that they should not gain weight within a very short span of time. Recently, I have got an experience. One of my PCO patients, she conceived with very difficulty with IVF, and she came within a span, she gained 10 kilo weight. So to my surprise, I asked her, what you weighed that you gained 10 kilo weight? And I thought surely she developed diabetic, but fortunately she's still not developed diabetic, but her chance of developing gestational diabetes is very high. So because their metabolism is so wrong, so the chance of getting, when they are hungry, because of the pregnancy, they are feeling hungry, and if they binge on the carbohydrate again, then they will be in trouble, and chance of gestational diabetes, which is, I think, the prognosis for gestational diabetes is poor, because first of all, we need to control it, but when it is already set, chances of baby having this problem and developing, all sorts of either growth restriction, placenta is not growing well, or baby is macrosomic, that is baby is growing excessive weight gain, and this mother's womb is very big, and chance of preterm is very high, and the fluid volume is very high. So it is kind of a very bad situation. So if we can prevent this happening, then we have to counsel our patient, and they should follow the advice of ours and dietitian. And other thing is little bit of exercise of 20-30 minutes normal walk. Also, I always tell them that this much of exercise you can do, so it's not that all the time, because especially IVF pregnancy, they do not move their muscle at all the time. They are just lying down, they're thinking there's otherwise they are going to miscarry, and if they are still having carbohydrate binge, then that is a trouble for us. So we need to counsel them properly, and they should know what is the hazard of this can happen, not only on her baby, and baby's adult life, baby will develop early diabetes and hypertension, this sort of problems. So we need to make them understand very clearly so that we can avoid all sorts of problems.
Thank you, Dr. Banerjee. Dr. Sorathiya?
Just I wanted to add that this woman, madam has rightly said that during delivery and during. The important thing is that this woman should be follow in the postpartum period. The postpartum period, once they deliver, they are all freak, and now they have the baby. Forget about PCO. Everything will be then. But every pregnant lady have the weight gain at the different ranges. So this woman should be counseled that you need to again back to the whatever you have started. So it should be properly counseled. You need the routine follow-up after 6 months or 8 months to start the again tailor-made approach to gain the whatever the weight gain or whatever the thing that to be taken back.
Thank you, Dr. Sorathiya. Dr. Madhupriya?
I basically think in these people, education and motivation is very, very important. We need to spend some time as physicians to sit with them to tell them why it is important for them to lose weight, because it is going to not only help them conceive, but also to have a healthy pregnancy throughout and to avoid the metabolic problems in the baby, avoid problems around the time of delivery, and even that acts as a planning for the second child. So it's important to continuously keep them motivated to shed few kilos of weight, to lose some calories, both with diet and physiotherapy. And this is going to be a continuous process, and it is not something that they have to do just because they have to conceive and they just have to go ahead with the fertility treatment. It's a lifestyle change, which means they have to continue this throughout their life, and that is what is going to avoid them and their progeny, their babies, from going in for a metabolic problem. And now, not only people who are on the higher side of the weight, we call them overweight or obese, these people alone, it's not enough to motivate them or educate them to lose weight. It is also important that polycystic ovarian patients who are on the normal weight side or who are on the leaner side of weight also need to exercise. Why is that so? Because they have a certain threshold for polycystic ovary below which the insulin resistance is more. There is good amount of this hormone, but still it is resistant to the action. But at a particular level of weight, they start becoming more sensitive to the hormone and they start working better so that they have good ovulation or egg release. So not only for obese polycystic ovarian women, also polycystic ovarian women with normal weight or those on the leaner side of the weight as well need to do weight maintenance or do appropriate exercise to reduce their insulin resistance.
Thank you, Dr. Madhupriya. Now, moving ahead, I would like to go ahead and ask this question. How effective are oral medications in achieving pregnancy? And what is the impact of oral fertility medication on PCOS pregnancy? Dr. Banerjee?
Yes, oral medications, yes, there are few oral medications we are giving to these patients regularly, which are very good and effective. One group of medication is to control their insulin resistance. There are one is we call is Bigomet, that is insulin lowering agent, or they decrease the resistance. Another is inositol group of medications. Those are also for in the decreasing the insulin resistance. But key thing is their weight control and low carbohydrate diet and good exercise. And other group of medication is ovulation induction, because they're not having period, their ovary is not functioning. In that group, we can do ovulation induction with certain oral medications. So some age-old medication like clomiphene citrate is used. Nowadays, letrozole is the first choice. We use letrozole just to stimulate their ovary so that they can have at least one egg ovulation. And then we can avoid multiple pregnancy for them, because if we are doing an IUI or IVF cycle, when we are aiming for multiple egg development, so chance of multiple pregnancy is very high in this group, especially in IUI. when we are using very low dose hormone, gonadotropin, for ovulation induction, that is injectable hormone, is not oral, then chance of multiple follicle development, multiple pregnancy is very high in this group of patients. So if some are responding to oral medication, then that is very good, so that we can have less chance of the multiple pregnancy, and achieving pregnancy is also very good. They need some progesterone support, and that is also orally we can give. And if they are not at all, some group of polycystic ovaries, some lean PCO are there who are very much resistant to the medication, and their insulin resistance is so high, though they are lean and thin, but still they have got a very high resistance. And in these groups, sometimes we see this very severe PCO with like follicle number is 80 or something, and it is very difficult, and AMH level is very high. So for them, it is very difficult to get ovulation with only oral medication. So sometimes we need hormonal injection or gonadotropin injection, that group of patients.
Thank you, Dr. Banji. Moving into Dr. Sorathiya on this.
So oral medication is as Dr. Banerjee said, there are the two group of the oral medication. They work with the different mechanism on the patient. The important thing, make that patient, the PCOS is anovulatory, the disease of anovulation in most of the cases. So make this drug will help to them ovulate and make the pregnancy easier. They are very much effective in most of the cases, but those who are not responded, it's very difficult. They are the usually candidate for IUI with the injections or IVF. So as Dr. Banerjee said, there are the two group of the drug. The second ovulatory drugs are the letrozole and clomiphene. Now letrozole is frequently available. Last year it is banned from the India due to there are a lot of issues. But this is the one of the best drug, and beauty of this drug is only produce the single, or at least in few cases there are the two follicles. So it's not intended for the multiple pregnancies. So that is also the benefited to the couple.
Thank you, Dr. Sorathiya, on that. Dr. Madhupriya, if you could.
Yes, to just add a point here, there are two groups of drugs which we use in polycystic ovaries, as already mentioned. One is going to be a group of drugs which will allow the hormonal imbalance because of the insulin resistance to come down. The other is to help the egg come up, the ovulatory drugs. So these two have to be used to the bare minimum, and basically it's a tailor-made protocol. Stepwise increment has to be done, starting with a minimal dose of a single drug, increasing it if needed by dose, or changing it to other group of drugs only when there is either a failure or a resistance to the used drug. Going ahead with the next drug appropriately is the choice. Even with best of the medications, some of the severe polycystic ovarian patients do not respond, they do not ovulate, for whom we have the last armamentarium called the lap ovarian drilling, which is least used nowadays, or IVF, which gives them best results. The flip side is, for people who are ovulating with the basic drugs, we do not know if the quality or the maturity of the eggs are good. Whereas in an IVF, we get to know if the maturity or the quality of the eggs in such people are good. We've seen that polycystic ovarian women produce a lot of oocytes or eggs, but the quality is usually a little less, or the immature eggs are more when compared to the normal population. So it is important to judiciously use these medications with appropriate dosing and tailor-made protocols, because it doesn't fit for all. The same medications and same dose doesn't fit for all. It depends on the age of the woman, it depends on the weight of the woman, it depends on the other factors like the male factor or a tubal factor associated, and it also depends upon the way they respond to the particular medication. So it's basically a tailor-made protocol for people, and it does succeed in most of the patients.
Thank you, Dr. Madhupriya. Moving ahead, what are the recent advances in IVF procedures? What are post-PCOS pregnancy complications with ovarian hyperstimulation syndrome?
This is the dreaded complication for any clinician. It is the ovarian hyperstimulation. But thanks to our recent advances in the management, we are using the medication, the protocol that is called antagonist protocol. So to avert this problem, and we are using a trigger injection, which actually we used to use HCG injection to trigger or the maturation of the follicles, which is utmost important thing in IVF. If proper maturation of egg does not happen, then we will not get any egg. So all the process, the IVF or expensive process will be futile. So we need to get this maturation. But previously, when we used to use HCG injection, that time chance of ovarian hyperstimulation in this group of patients was very high, no matter how low dose you use it. But to nowadays in an antagonist protocol, when we are using agonist hormone, that totally, almost totally, not totally, but almost totally prevent this complication in this group of patients. Basically, ovarian hyperstimulation is a condition when when we stimulate the ovary, they become suddenly they swollen up and they secrete, they start to ooze things from the surface of the ovary, and that causes some distension of abdomen, and distension can be so severe that this distension reaches her chest as well. So it's called pleural effusion, and this is ascites, is the full-blown ovarian hyperstimulation. Patient end up in ICU. So chance of morbidity and mortality increases so much in this complication. So it's best to avoid. And thanks to our recent medication, it is kind of our last few years, most of the clinic, I'm sure we are having zero HSS, no HSS at all. And our stimulation protocol is also such that it is a tailor-made protocol. So which patient will respond to which hormone, that the doctor decide, because not all the polycystic ovary is same, because some polycystic ovary we are seeing like 80 follicles, some are 25 follicles, both are PCO. So some are lean, some are fat, some age is kind of 25 to 30, some are 30 to 35, some even 40 with polycystic ovary and primary they are coming for IVF. So different group of patients will respond to different amount of hormones. So we need to judge it beforehand, how much hormone we are going to give our patients, so that we get an optimum number of eggs, which should be 15 to 20, and we should not get at all, not as a single VHSs we will have in our clinic. And another thing is always we need to check day to day, the close monitoring, how many follicles recruited, how much they are developing, if they are developing at all, any fluid is coming in the abdomen. So we need to have a kind of a red sign. Okay, it's coming. So she might develop polycystic ovary syndrome. So we cut short then the stimulation. So the different measures are there to avert this polycystic ovary syndrome. And we do, it is a kind of a compartmentalized treatment. So whenever we stimulate a polycystic ovary for IVF, we never give them the pregnancy in the same cycle. It is called nowadays all these cycles. So whenever we make the pregnancy and then we freeze all the embryos, we do not transfer at all one embryo. So we next cycle, when the ovary is in a normal shape and she has got no risk of OHSS, at that time we try to give them single blastocyst. That makes their the outcome very good.
Thank you, Dr. Banerjee. Moving ahead, Dr. Sorathiya, we may be running out of time. So if you could quickly wrap this up with.
So there are a lot of recent advances in last 10 years. The first is the better availability of the better drugs. Second is the better protocol that prevent the OHSS. Third is better lab quality, where we make the good quality embryos. Better freezing techniques for the embryo. So we have the better freezing of embryo. Fourth one, we are now moving from the double embryo or transfer to the single embryo transfer. That is the most important advances, I would say. So it improves the maternal safety. Always the multiple pregnancy is always difficult, and the high risk pregnancy. So we are moving for the single pregnancy in the IVF. So as per these are the most important advances.
Dr. Madhupriya, if you quickly wrap this up.
Yeah, so basically, we have come a long way. We have moved forward since the time of inception of IVF. We have come a long way in the treatment of polycystic ovaries. And now, as we already saw, an elective single embryo transfer, similar to that of a natural treatment, even in IVF cycles, and having 0% OHSS clinics will definitely help in moving forward.
Thank you so much for that, Dr. Madhupriya. Now we can take some audience questions. So our audiences have asked a few questions. So we can just go ahead and address one of those, a couple of them actually. So there is a question by Dr. Mukti Sharma. It says, if first IVF is a failure, what would be the first step to be taken? Why don't IVF centers work on wholesome remedies, some research work on each patient profiles while only with monetary centric? Okay, every reports of hormones, everything was normal. So I think basically what Dr. Mukti Sharma wanted to ask is, if attempted IVF is a failure, what are the first steps that need to be taken after that? If someone is going in for IVF treatment, I guess that is what she's asking.
So if I am answering the question, if there is a failure, we always try to find the cause, why it is failure. So that gives us a good, otherwise we will never succeed. So for success, we need to know why this is failure. So sometimes we see when we are doing in a frozen transfer for this group of patient, as I have mentioned, that all freeze is done. So then in the frozen cycle, we sometimes see the endometrium is not developing well. And probably that is another a problem for these patients. And then one cycle, we might cancel the cycle so that the good development of endometrium is there. Sometimes blood flow is not good. So we need to, there is a thing called implantation window. So if we miss an implantation window, then we are never going to succeed. And unfortunately, there is no fixed day that we can say, okay, this day to this day is the implantation failure. So for every patient, it is different. And for every cycle, in a same patient in different cycle, implantation window will be different. So we need to judge we are in a right position to transfer the embryo in first place. So we judge so many things: ultrasound factor, heart cycle factor, the blood monitoring with some hormones, those factors, and overall taking wholesomely, okay, this is the right time for the patient. I think from my experience, then we transfer the embryo in a right phase. So if we are transferring an embryo like a single blastocyst, we have to be right amount of progesterone should be given for such a day so that we can match the implantation window of that patient. If we are not in a right time, then most of the time there will be a failure. And sometimes another cause of failure is during the transfer, there is a problem. Suppose during transfer, some endometrium going inside the cavity is very difficult, then it becomes a very traumatic transfer. Then also this is going to be a failure. Or we mention in our note that this patient should be done in a different way because it is a traumatic transfer. There is a chance of success is less. Or sometimes we give the embryo and sometimes we see the embryo is moving because the uterus, the endometrial lining of the uterus is very contractile, and we in front of our eyes the embryo is dropping. Those things has to be mentioned in the note that we have done this and there is some problem and that's why this is failure. Then so that next time we can do it is differently so that this should not happen.
Thank you so much for that, Dr. Banji. There's one question by Param Desai. He says, in case of inositols, what is the ideal ratio for treatment and what is the rationale of different combinations like 3:1? Dr. Madhupriya, if you could take this question.
I personally do not use inositols in a larger way, but still use of it in 40:1 ratio is told to have a better control over the insulin resistance and increase the insulin sensitivity. And of course, a combination of these are important in a particular ratio to crack the resistance and increase the sensitivity. So the drug combination as suggested by the mechanism of action is important to go ahead. But I personally don't use it unless I have a very abnormal glucose tolerance test in the patients with polycystic ovaries, where metformin or the insulin sensitizers are not able to help.
Thank you, Dr. Madhupya. I think we'll take one more question. Dr. Sorathiya, there's one question by Veer Vaseem. He says, in some cases of PCOS, some doctors are suggesting hormonal injections after trying progesterone and medroxyprogesterone.
Yes.
This hormonal injection safe? Does it have side effects?
So as is our discussion that the few people, when the only aim is to get the number of follicles, so she could be that the ovulation. When there is a oral medication failed after the appropriate dosing and everything, then there is a role of the hormonal injection. Hormonal injection are safe, usually doesn't have do not have any side effect. The only thing with hormonal injection, when used for the IUI, usually 2 or 3 follicles would be there, or when we do the IVF, number of follicles are different from the each person to person. But definitely hormonal injection are safe and they doesn't carry any side effect.
Thank you so much for all of you all joining here and giving us your valuable inputs for this panel discussion. Dr. Madhupya, you raised your hand.
Yes, if I may have 30 seconds to actually answer one of the questions asked by one of them, that is the IVF, if there is a failure, what do you see? See, basically there are 4 factors. One is the sperm, the oocyte, the endometrium, and the lab. So we need to be very meticulous in identifying where the problem is. And believe me, even if everything out of these, because each IVF specialist is going to see all of these and find out what the problem is and correct it. Despite all these, the implantation is only 50%. So let's be more realistic towards IVF cycles. And it is not possible to have 100% success with IVF. And it is important to convey this to the patient, why we are doing an IVF and what could be the success rate, what is the possible failure rate, and how many cycles does it take or how many embryo transfers it takes to give them the maximum success rate. And that's not going to be 100% in everybody.
Thank you so much, Dr. Madhupya, for concluding this discussion. And I think we can conclude the discussion here. Thank you so much for joining us.
Thank you.
Good evening. Thank you.
Thank you very much for moderating the session very well. Thank you very much.
Thank you so much.
Thank you, Prabhat.
Thank you, Dr. Sorathiya. Thank you, Dr.
Thanks all my other panelists as well.
Thank you. Bye.